Richard?
Thank you very much, Alain. Who's got ECMO centres in their unit? Hands up. So there's a few who do, and a few who want to know something about it. That's fine. Well, we'll go through it on a somewhat logical basis, I hope, and we'll do the children first, because it was in children that ECMO was really first successful. Well, what is it? It's a use of basically a heart-lung machine in the ICU. It only became possible when membrane oxygenators developed, and the distinction between the membrane oxygenator and what went before was all the previous designs of oxygenators involved direct contact between the blood and oxygen. Until the blood phase and the gas phase was separated by the membrane, it was not possible to do support for longer than a few hours. The man who pioneered a great deal of all of this, particularly in children, was Robert Bartlett, who's shown there with his holding one of his implantable lungs. So that's a glimpse of the future. Those devices will soon be going in people's chests. They're going in animals' chests now, but he's done a lot of work on the pediatric age group, and has also done a certain amount of work on the adults, which has kept us all going. This was the first case he did. 1975, that was a child with meconium aspiration syndrome, PPHN. He did that at Orange County, where he was working then. He moved to the University of Michigan soon after that. This is the same young lady, aged about 22. The circuits he used then, and we used up until about 2008, were based on this sort of design. So you had a venous drainage line going to a bladder box which controlled an occlusive roller pump, a membrane lung with a membrane being made of solid silicone spirally round a center. Blood then went from there to a stainless steel oxygenator and returned usually to the carotid artery, but also sometimes to the right atrium. So you need to get the concepts of VA and VV. In children, VA has been the predominant mode of ECMO in most centres in the world. I don't necessarily agree that it's the right one for most children, but that's what is generally done, particularly in the States. This is what our version of that circuit looked like about 1995. Here's the membrane oxygenator here. Lots of tubing, bridges, Galveston diamonds, all of that sort of thing. These circuits had a priming volume of about 600 cc's. On the basis of the child that's on the cot there, that's about twice the baby's blood volume. 2009 was a defining year in ECMO history for a number of reasons. There was new technology widely available which had not been available before. The CSER trial on adult ECMO was published, and there was also an H1N1 influenza pandemic which provided us with almost a unique opportunity to study severe respiratory failure in young patients with almost no comorbidities. This is now the circuit that we're using in a baby. This priming volume of this circuit, which has got a Levitronics pump, a little Medos oxygenator there, is 120 cc's. So instead of being double the baby's blood volume, it's now half the baby's blood volume. Most neonates who are polycythemic when they're born, you can put on ECMO without any blood at all. You can top them up later. So you can clear prime these circuits because their volume is completely different. And this has revolutionized all aspects of ECMO, both in neonates and children, but also, as Alain will be pointing out later, in adults. And this is what the console looks like. It's a very straightforward thing, and you can see the blood flowing through that sort of circuit. The other thing that's happened about the same time was the development of these double lumen cannulas, which are wire reinforced. They're made by Avalon. They're extremely expensive, about €2,000 a go, something of that order. But they are very efficient vena-venous devices, and they don't kink. The only problem we've had with them is that a few patients have had late tamponade from this. We don't actually understand why, but 5 out of 60-odd patients that we did this technique, when they were all already better and had multiple echoes which showed that they didn't have pericardial effusion, suddenly developed hemopericardiums. So we bailed them all out, but it's a bit nerve-wracking for everybody involved. So there is an issue with the smallest cannula in the smallest patients, but outside the neonatal age group, these work extremely well. So when should we use it in children? Well, the predominant use has always been in respiratory failure, but obviously there are a lot of cardiac surgeons here, and increasingly people are using it for cardiac failure, whether it's post-operative or pre-operative. There's also a lot of work being done on resuscitation, both in adults and children, related to the use of an extracorporeal circuit. Now, the selection of patients is always the key. The technique works in terms of being able to provide support, but who should you support? And the principles for selection of patients is actually the same as for any type of extracorporeal circuit. It's not unique to ECMO. And the key first question is, does the patient have a potentially reversible problem? If they don't and they're going to die, it will prolong death for a bit, but they will still die, and there's no point. The only point is some people are using ECMO circuits effectively to keep organs alive, although the patient's dead, so that they can transplant them. So there is a bit of that going on. A key aspect of reversibility is how long patients are ventilated for. Now, this is a controversial area, but in general, ventilator lung injury does affect the degree to which a patient is going to survive. And these are the sort of times that we use, not as absolute rules, but guidelines. A neonate that has been thrashed on a ventilator for more than 10 days will generally do badly. Child, 7 days, and adult, 5 days. Now, we've got survivors beyond those, but it at least gives you the background to know where you start. You're not giving these patients who've been ventilated 14 days as an adult a 67% survival figure, because that will not be fair on the relatives, because it's not true. And to just make that point, this is the swine flu data showing the relationship between survival of those who had ventilation for more than 7 days and those that did not. Now, clearly there are survivors in the more than 7 day group, but there aren't as many. Now, the science of neonatal ECMO has been a bit controversial over the years, and it started with a randomized trial done by Robert Bartlett, where she used a modified design known as Play the Winner. Now, you can use this design and you can end up with some very funny results sometimes, and he did. They started with 50 patients with severe respiratory failure in newborn. They had 36 who improved, 14 who were unresponsive to conventional management. 2 weren't in the trial because the parents refused to have the children in the trial. The first patient was randomized to conventional treatment and died. You then pursue the successful treatment until that then fails. Well, they did 11 ECMO patients having switched from conventional. They all survived, and you end up on a predictive value of a p-value of 0.001. But obviously, as clinicians and biologists, you raise an eyebrow where you've got a conventional group which actually only has 1 patient in it. But statistically, it's valid that this is a p001 result. A lot of criticism was heard about that trial, a lot of it coming from Boston. So they were basically told, put up or shut up. So they organised a trial of their own, and they used, again, a modified trial design, but one, I think, which was very clever. What they agreed to do was randomise fully until there were 4 deaths in either arm, and it turned out it was in the conventional arm. Having done that, then 20 more patients were done with the more successful treatment. So although you didn't have equal randomised groups, you did actually have a lot of information about the treatment group, i.e. the ECMO group, and you did have a reasonable number of patients to compare them to. And that again showed a significant benefit for ECMO. The third trial was done by ourselves in the UK, Newcastle, Leicester, Great Ormond Street and Glasgow. And this was a fully randomised trial with a larger number of patients than anything that had gone before. And again, it showed significant benefit assigning to ECMO. And these are the sorts of results that you get for neonatal respiratory failure. You can see survival for meconium aspiration syndrome is as close to 100% as you can get in clinical treatment. It's 97% on our practice and 94% in an international registry where there are thousands of patients being treated by all sorts of different people in all sorts of different healthcare setups. Diaphragmatic hernia, not surprisingly, has a far less good survival, but this is not because ECMO doesn't support these babies. It does. It's just they basically have lung hypoplasia. The other group that don't do particularly well are the ones with severe sepsis. This is usually group B strep, but it's also other things as well, like herpes simplex and pertussis and a few other things. So there's some very nasty infections in there if children get them and then need support. The other important difference about our trial with previous trials is that these patients were then not abandoned from the scientific point of view. They're still under study. So we now have 4-year and 7-year data on these children, and basically the results show that it's the severity of the disease that causes brain injury rather than the means by which they were treated. So there's no real worries about ECMO treatment of these patients, even with ligation of carotids and so on, is affecting the long-term follow-up of these children. The other interesting aspect of the follow-up of these children is that those who were managed with ECMO rather than conventionally have less symptomatic respiratory disease. So far fewer of them have got asthma and far fewer of them are under treatment for things. And this is not surprising, because if you had severe meconium aspiration syndrome, you will need usually 3 or 4 days of ECMO and 1 or 2 more days of ventilation. The same baby can be managed conventionally on an oscillator and thrashed, but they usually require 3 or 4 weeks of ventilation. And that is reflected in the long-term outcome of these children's lungs. Just to add on to the sort of studies that we've done in this country, this study is completed from the trial point of view, but it's not published yet, and the data has not been fully analysed. This is a study using the ECMO circuit for hypothermia in the immediate period after birth of badly asphyxiated children. So we know that cooling reduces apoptotic damage of the brain in patients who have been severely asphyxiated. And this is obviously a high-risk group from the work we'd done before. So by the end of this year, we should have a clear answer from the next study whether we should be actually aggressively cooling these patients when we put them on, as well as just supporting them. Now, in older children with respiratory disease, there's very little data to support the use of ECMO. The only data that exists comes from prospective database or collective databases. There's the ELSA registry, which is the data that I showed you on the right-hand side of that slide. This is the international registry that we all send our data to. There's also the Paediatric Critical Care Group, who pool the data from a lot of the major PICUs in the United States. So there's these 2 big databases, and if they looked at the factors that affect survival in the Paediatric Critical Care Group, they found, rather surprisingly, that availability of ECMO within an institution was a positive result. So if there are about half the big neonatal, big pediatric ICUs in the States have ECMO capability, and about half don't. Those that have it get significantly better results than those that didn't. So that was the first set of data. If you then do match pairs between the databases, you can also get some reasonably good matches for patient age, diagnosis and severity of illness. And again, ECMO comes out on top if you do that. But there's no randomized study in children, and there never will be. It's just too difficult to do because of the variation in age, diagnosis, and so on. And there's a relatively small number of patients who need support per year, so it would take forever. We've always done older children, and this is the sort of data that we've had. Again, depending on what they've got, you get that sort of result. So viral pneumonia, something like RSV in an infant, has got very good results, something like 90% survival. The same age patient presenting with bronchiolitis who turns out to have pertussis, it's about 90% the other way, 90% mortality. It's an evil disease. So we can support these children, but their outcome depends far more on what they've got than what we do. Why does neonatal respiratory failure work so well with ECMO? Well, I think it's very simple. We all know that pulmonary hypertension in the newborn is related to oxygenation. And the harder you ventilate these children, the more hypoxic they get, and you get in a vicious cycle with right to left shunting both in the duct and across the atrial septum. If you put oxygen into the equation, that equation then goes backwards, and the pulmonary arteries relax, they become easier to ventilate, they shunt less, and so on. So ECMO is a very good way of unscrambling that particular physiological problem. Now, there's no data to support the use of post-operative cardiac surgery in children, but as you can see from the registry, more and more people are doing more and more cases, and most people would say that having post-operative ECMO available in a congenital heart unit is now a standard of care and required. So there's no trials or data to support that. All it is audit data. Now, when should you use it? Because you've got to make the same judgments for cardiac disease as you make with respiratory disease. In the post-operative period, the commonest indication is failure of pharmacological support. Next commonest is failure to wean from bypass, and patients put on theatre on ECMO there, and that's a fairly easy endpoint. If you can't come off bypass, you're dead, so if you put them on, then at least you're playing for time. Cardiac arrest is a controversial one because it depends on how available you are to put these patients on. There are certain very unstable patients who may present in the neonatal period like birth asphyxia, a typical one being infradiaphragmatic TAPVD, and these babies go on because you think they've got respiratory disease, and you have a good scan of them and you realise that they've got heart disease. So some of those happen by mistake, but there are a few patients that present so ill that it's worth stabilising them on ECMO and then operating on them subsequently. We've also had a few patients with malignant dysrhythmias who've been almost impossible to manage either medically or electrically for a while. And again, you can stabilise these patients, take them to the cath lab, do the EP work, do some ablations, fiddle around with the drugs, not worrying about what's going to happen to the heart function or blood pressure while you do it. So we've done a small number of patients like that. And then, of course, there's the issue of transplantation and myocarditis, and some of these patients we bridged to survival and some are bridged to transplant. The contraindications are obviously there. If you take a patient who's been thrashed for too long, you'll get no useful benefit from ECMO. So if you're going to use it, you've got to choose the time to use it effectively. I don't think anybody doing PICU has got any illusions about what these patients look like. Cardiac arrest, I've mentioned. You've got to decide whether you can put patients on ECMO in a time that's going to potentially benefit patients. There are obviously issues if a patient's had a prior arrest and you don't know what the neurological status is likely to be. And there are some patients where you know they've got brain injury before you start. In terms of cannulation, there are different ways of doing it. For respiratory disease, we generally do vena venous if we can. For cardiac support and for patients for one reason or another you can't cannulate VV, than veno-arterial, which is usually done open as a cut down. Obviously, if you're in theatre with the chest open, you have an option of doing it open chest. Having said that, I much prefer, even if I'm going to do that, and have the chest open at the time you want to go on ECMO, I usually separately cannulate through the neck and then discontinue bypass, because it's much easier to manage in the ICU. Now for vena venous, you've got options of the double lumen cannulas I've shown you, or 2 or 3 cannulas even, which are separate single lumen disease. So this is the usual sort of cut down in the neck. It needs to be done carefully to dissect the vessels out. And these are the sort of things you get. This is a meconium aspiration on VA with a couple of cannulas in. The venous cannula, the tip of it's there, has a dot on the end of it. These are the sorts of double lumen cannulas that we do with what we call semi-Seldinger. So we cut down, expose the vessel, cannulate it with a wire, and dilate the track up, and then these rather fragile double lumen cannulas can then be put in over the wire. So you don't ligate the vessel, and when it comes to taking it out, all you need to do is pull it out and press on it or put a stitch in the skin. You don't have to do a formal re-exploration. And that's what one of these big double lumens looks like in a baby with RSV. With the bigger children, then you use Seldinger technique. This is a single lumen cannula, and you can just put those in over a wire with screening, and that's what a biggish cannula in a 4-year-old looks like. Now for cardiac ECMO, there's an important consideration, and that is the issue of left ventricular venting. If myocardial function is extremely poor, you'll get pulmonary edema. Some patients have got just enough function that you can avoid venting them, but many don't. So you have to use one of a number of techniques to vent the left side of the heart. If you have just done or are doing a cardiac operation, you can leave a blow off in the right atrium between the left and right side across the atrial septum. If you do that, that's usually enough to prevent pulmonary edema. If you haven't done that, or there are a myocarditis patient that comes de novo, then the cardiologist can do that in the cath lab, usually with a blade. Now the thing that is most difficult with ECMO patients is not the putting them on, it's not the stabilising them, it's managing them if they start to bleed. And this is something that sorts the men from the boys, the experienced units from the inexperienced units. And you need to be aggressive if you're going to manage this effectively without the children getting too bashed about by bleeding. And certainly those post-cardiacs, you've got to be prepared to pack the chest and re-explore, sometimes multiply. We found that closing the sternum actually makes a lot of the bleeding better by the fact that the sternal edges are together. More than that, you then need a stepwise approach to the pharmacology and the products. Now there's a lot on this slide, but actually with the new circuits we can forget most of it. Yes, you need to optimize the platelets and the INR and the fibrinogen and things, but these circuits will actually function perfectly well for hours and days even without heparin. So if you're in real trouble with heparin, whereas it used to be a big deal to stop heparin on the circuit, it no longer is. So yes, we do these various other things, but we stepwise decrease the heparin. And if they're still bleeding, even on 5 units per kilo of heparin, then we'll stop it. The old circuits with the bladders and things, they'd pack up within 6 to 12 hours, usually, if you did that. These modern circuits with the impeller pumps and the Medos oxygenators do not do that. And we've run them as long as 7, even 8 days without any failure of the circuit or with any clot forming within it. So this is an important change. So what sort of results do you get post-cardiac? Well, generally quite good. And these are our results and the published results in the ELSA registry. So even though these children, by definition, would be fairly desperately ill, having had major cardiac surgery usually, their survival is really quite good. And one of the things that's changed is those who were cannulated in theatre used to have a horrendous mortality. It used to be down in single figures. Then it went to 30% survival, and now it's almost 50% survival. So what we've learned is how to manage the bleeding in these patients, because it was the bleeding that killed them. Right, I'll leave it there.
Okay, so I have many slides. I'm going to skip some of them for the sake of time and for having a discussion between us at the end of this session. So, what is the ECMO circuit? The ECMO circuit is made first of a pump. As Richard said, it has evolved a lot in the past 10 years. Now it is closed circuits with centrifugal pumps. They are highly reliable. They can deliver high flows up to 8 liters per minute. The oxygenator has also changed a lot. It's made mostly of polymethylpentene. It's heparin coated, and it's very important, as Richard said, because you can run this circuit without heparin for a few days. And they are also long-lasting devices, which can be effective, efficient for even 3 to 4 weeks. The controllers are moving from old machine to newer system with many more securities and sensors, especially pressure sensors, which are very important to make the circuit running smoothly. The cannulas, very important as well. We use a different setting. We use very few Avalon cannulas for VV ECMO. We mostly use a setting with 2 cannulas for VV. So what is very important, whether it is VA or VV ECMO, is to use a large drainage cannula. Because as the Poiseuille law says, the flow is the function of the force power of the cannula diameter. So you have to maximize drainage cannula diameter to decrease pump speed and pressure into the tube and to decrease blood trauma. So now VA ECMO is probably the most useful machine, the first line device in the context of refractory cardiac failure, because it's very easy to set up. You do not need to open the chest. It can be done under local anesthesia. It's perfect for emergencies. It provides high and stable flow up to 7-8 liters per minute. And it's also a heart-lung machine with simultaneous cardiac and pulmonary assistance. And for cardiac failure, it can be used as a bridge to whatever seems reasonable, including recovery, bridge to another device, transplantation, or even withdrawal if the patient has a bad evolution. And it's also a low-cost device. It's 2 to 40 times cheaper than bigger machines. There's the program here at La Pitié. We began the program in the early 2000, and it's increased a lot beginning in 2005. And last year we did almost 300 runs. Was mostly post-surgery at the beginning of the activity, but now we have a lot of indication in medical patients, especially ARDS and also medical refractory cardiogenic shock. So the setting for VA, we still use a limited cut down to access the vessel. The vessel are then cannulated using the Stilldigger technique. For VA, we use here a little reperfusion line to prevent leg ischemia. Other teams now are cannulating the patients only using the Stilldigger technique, only percutaneous, with ultrasound probe to assure that the guide wire is in the vessels. It can be an option. It's possible if the patient is pretty stable. It might be more difficult in obese patient, and I think it's absolutely impossible in the context of cardiac arrest. So the big question, the second big question is to ask when initiate this kind of mechanical assistance in the context of refractory cardiac failure. There are many parameters that needs to be evaluated. First, the etiology, the treatment, and the time course of the disease, the treatments which have been administered to the patient, the clinical status. In some patients, it might just be futile to insert ECMO. Other subtle signs, nausea, abdominal pain, alteration in consciousness. What is very important is to detect the first signs of organ failure, especially renal failure and hepatic failure. Doppler echocardiography is also very useful, very simple parameters. If the LV ejection fraction is below 20 and the patients have signs of low cardiac output, very simple signs. If the aortic VTI is below 8 or 7 centimeter, it's serious. This is a study we did in our institution showing that the signs here of renal failure and hepatic failure were highly associated with a poor prognosis in the patient. Note also that patients who got ECMO under CPR had very poor outcomes. So as I said before, ECMO can be used at a bridge to whatever seems reasonable in that situation. Should we use a BiVAD instead of ECMO? For the patients who got myocarditis, we took the opportunity of the switch from a BiVAD to ECMO for these patients in the year 2003 and 2004 to compare the outcome of the patient before with a BiVAD and after using ECMO. With a small series of patients, 5 and 6. There was no difference between these two groups of patients, but what we got is that the duration of ECMO support was lower for the patients who got ECMO, probably because it's more easy to withdraw the cannula than to go back to the OR. It was a thoracic BiVAD which was used at that time for these patients. No difference in the death rate. But less complication with ECMO, less transfusion because probably it was there was no the chest opening and all the problems of bleeding related to the BiVAD. Also less liver and renal complication. Here is the BiVAD patients and here ECMO. You see in the days following implantation there were less complication with ECMO. So now a few slides of some of the studies. Now, many studies in the literature reporting the experience of a VA ECMO in the context of refractory cardiac failure. This is a good one. Once again, it's the before and after study showing that for those patients who have profound cardiogenic shock in the context of acute MI with ST segment elevation, the mortality here was very high before the ECMO program. It reached 72%. After the introduction of ECMO, it dropped to less than 40%. Here's the Kaplan-Meier curve. Here it's another series of patients we did in La Pitié. It's only myocarditis patients. Most of the patients got ECMO. Most of the patients got peripheral ECMO. And the long-term survival of these patients were 68. It was 68%. Probably is the best indication in terms of outcomes for these patients who got ECMO. After cardiac arrest, there is a very important study which published in Lancet in 2008 from Taiwan, from the group from Chen and collaborators. They did a prospective matched maternal propensity score cohort of patients for patients who had witnessed in hospital cardiac arrest. It's very important. Witnessed in hospital cardiac arrest of cardiac origin. What they have shown in that study, it was a better prognosis for those patients who got ECMO. But they got ECMO within 10 minutes of refractory cardiac arrest. The ECMO team in the hospital was called within 10 minutes of the collapse. And for most of these patients, the ECMO circuit was running within 45 minutes following cardiac arrest. And this is another very important information. You need to have a full functioning ECMO system within 60 minutes following collapse. Otherwise, mortality is going to be very, very, very high. This is another study published last year in critical care from Lapitié, this time focusing on out of hospital cardiac arrest. There was 51 patients in that study and only 2 survivors. And one of the survivors has still neurological defect. It said that in the paper that it was good, but we had this patient in our unit. It was not that good. So, yeah, of course. I think if it's not possible to run the ECMO system within 60 minutes following collapse, it's not useful. It's a lot of resources, a lot of cost, a lot of energy for the whole team of the cardiac surgery department and the medical department. So I think it's not wise to do that now, and we have changed the way we deal with the patient now. Most of these patients now are in the donor after cardiac death line. What is also very important when building an ECMO program is to have a mobile team. It is very useful for cardiac indication, but also for respiratory indication. These the results of our ECMO team for cardiac patients going to be published in the European Journal of the European Society of Cardiology. This is a study of 87 patients between 2005 and 2009, with mostly cardiogenic shock following acute MI in these patients. Overall survival was 35% in that series, close to what is observed in big series of patients with cardiogenic shock following acute myocardial infarction. And what we have shown in that paper is that there was no difference when matching the patients who got ECMO in the department and matching to patients who got ECMO outside with a mobile team. There was no difference in mortality for these 2 groups of patients, providing that you go quickly to the center and to have a network working together with the referral center, which can send very rapidly a mobile team as soon as the patient has been diagnosed to have refractory cardiogenic shock. ICU management, ECMO VA, peripheral VA ECMO has some limitation. It can be run for 2 weeks, 3 weeks, but not more. The patient has to remain supine in the ICU. There might be complication, including hemorrhage, embolism, acute leg ischemia, infections, stroke. The pump is highly preload dependent, delivers a non-pulsatile flow, although I don't think it's a problem for a few days. And the big problem, the big issue is also pulmonary edema. For those patients who have almost no residual cardiac function, when you put them on ECMO, you increases the afterload in the circulation, so it's going to be more difficult for the heart. And most of these patients, the heart just stopped, and there is no residual LV ejections. So there is a risk, an increased risk of pulmonary edema, an increased left and LV and diastolic pressure in these patients. So there are a few ways to decrease LV and diastolic pressure. First, using dobutamine to try to improve LV ejection, to decrease ECMO flow. For some patients, you might decrease a little bit ECMO flow. We have been using now for all these patients the balloon pump, and we have done little studies showing that with the balloon pump, it's possible to decrease LV and diastolic pressure from within 5 to 10 millimeters of mercury. Arterial septostomy is an option, transseptal LA drainage. The Impella, we have been using also the Impella, the big one, the 5.0, which is inserted surgically in the patient as a venting device in the left ventricle. It works. It works for a few days. The problem with the Impella device that it's also fragile. After 5 to 6 days, it can just stop in some patients. So there is other ways to deal with patients. We now move to long-term central ECMO for the patients who are still doing poorly with organ failures, and in the patient it's not reasonable to insert a big VAD, either a left VAD or a total artificial heart. To buy time, now we move to peripheral ECMO, to central ECMO, using 2 ECMO systems. One on the right side from the right atrium to the pulmonary artery, most of the time with an oxygenator, and another ECMO system from the left ventricle to the aorta. So basically, it's a BiVAD using continuous flow pumps for the ECMO system. We use the regular ECMO pumps or the Levitronics magnetic pump for some patients as well. In the ICU, it's very important to, the surveillance of this patient is very important. You have to be sure to not fold the lines. There is no tension. It's very important to maintain the line along the leg axis to prevent vessel tear. Some of these patients will develop massive bleeding due to arterial tears, so also special attention when moving the patient. In the first hours following insertion, it's very important also to watch for leg ischemia, especially if there is no reperfusion line inserted. When the lines are kicking, you have to check for hypovolemia using transesophageal or transthoracic echocardiography. It's very frequent in the case of multiple organ failure, and especially following cardiac arrest. So most of these patients will need a fluid or many fluid challenges. And also you have to check for the tip of the drainage cannula. If the tip of the drainage cannula is in the IVC, there might be problems with the drainage. It has to be in the right atrium to have a good drainage of the blood. Fibrin deposition is frequent. It's not an indication for changing the whole circuit. It might become an indication if the oxygenation capacity of the machine is decreasing, but for most of these patients, little fibrin deposits are seen, and it's not a big deal. This is a problem everybody should know. It's very important when you're doing VA ECMO in a patient who is going to recover, when the heart is going to recover, and especially the case for patients who have myocarditis, the patients who have drug intoxication, Takotsubo, and some patients actually after myocardial infarction. If the lungs are impaired, if the patient has also developed ERDS, it might be inhalation pneumonia or whatever, they're going to be, when the heart recovers, a competition of the flows between the heart, which is recovering, and the circuit. The circuit provides oxygenated blood, but if the lungs are failing, the blood which is going out of the left ventricle is going to be highly deoxygenated because the lungs cannot oxygenate the patient. In that case, it's going to be what we call the Harlequin syndrome, with the blue head and red legs. So you have to monitor LV function recovery in these patients every 3 hours when the heart is recovering, because for some of these patients it can go very quickly. And also to check for oxygenation with a SpO2 probe and blood gases on the right hand, on the right here. In case of profound and refractory hypoxemia, it might be an indication to switch from VA to VV in these patients to support the lungs. Biological surveillance, with a new generation circuit, we have decreased a lot the level of anticoagulation. For most of these patients, they got very little heparin, especially for VV, a little bit more for VA. We target now with the APTT 1.1, 1.3, the control for VV, around 1.5 for VA. In some patients, we might use aspirin, especially if the platelet count is over 100. And in some patients, especially if you're acute MI, they might also get aspirin and clopidogrel. But the big problem is bleeding. And in case of hepatic failure, multiple organ failure, consumption, the patient might bleed, and it's possible to stop heparin for a few hours, even days. The transfusion threshold we use, and that might be a controversial issue, especially with Leicester and in the LSO group, we use regular ICU transfusion thresholds for these patients. We maintain hemoglobin between 7 and 8 grams per deciliter, and we do not transfuse platelets if the patient has over 20 gig per liter. Hemolysis is also a problem. It is more important if there are high pressure in the cannulas. So that's why you have to use big cannulas to decrease the pressure in the tube. But it might also happen because there are clots in the cannula, or if the patient is hypovolemic. The patient might have bloody diuresis. And in these patients, it's also very important to have at least once a day a check for serum-free hemoglobin, which is an indicator of hemolysis. Echo is very important at each step of the procedure for insertion, to verify the correct positioning of the venous cannula in the right atrium, and also for the recovery process. This is a study, I will skip most of these slides, we did on patients we recovered from cardiac failure, and we've shown that there are indicators, aortic VTI and the tissue Doppler velocity of the mitral annulus, the systolic velocity, were closely related to a good prognosis and successful weaning. So now a few words on VV. VV ECMO, it's an old story. It began in the 60s and 70s, and mostly in children, as Richard told us a little bit before. There's been a paper published from the LSO registry 3 years ago on almost 1,500 patients with severe ARDS, and there was good results. Almost half of these patients survived to hospital discharge. It was young patients with a median age of 34, and most of these patients were supported with VV ECMO. What is very important for VV is when talking about the prognosis of the patient is to select a good population of patient. And probably one of the most important predictors of the outcomes, there are two prognosis predictors: the age, older people do poorly, and probably the most important criteria to select a patient is the number of days of mechanical ventilation before ECMO. And probably if the patient has had more than 7 days of mechanical ventilation, it's going to be more difficult. In that study, also using VA ECMO for respiratory indications was associated with a poor outcome as compared with the patient who received VV, and we'll discuss that a little bit later. Then came Giles, the Caesar trial. You all know that study, which showed that ECMO was beneficial for ARDS in adults. With data also from the H1N1 pandemic, data from the South Hemisphere. This is data from the ANZICS in Australia and New Zealand, showing that for a cohort of patients who received ECMO, these were less sick patients, young patients, but sick patients. They were all on high FiO2, high PEEP, with high pressure ventilation, low pH, high PaCO2, and mortality of this cohort of patients was very low, only 25%. These are the results also well from the UK. The strategy of transferring a patient to ECMO facilities. There was a cohort of 80 patients who were transferred, and compared to another cohort of patients who was not transferred to the ECMO centers. Of the 80 patients, around 60 got ECMO, and when doing statistical analysis and matching the patient who were transferred and not transferred, it was possible to show there was a benefit for the ECMO referred patients. Other indications, trauma, good indication also in experienced centers. In lung transplant patients, those centers who do lung transplantation, it's also a very good indication before transplantation as a bridge to transplantation, because it's possible to prevent intubation in mechanical ventilation with ECMO, and also post-op for those patients who have graft failure. I think it's also a good indication in the case of massive pulmonary emboli instead of surgery in most of the patients. So see a study from Bob Bartlett group in Ann Arbor showing that. Guidelines, these are the LSO guidelines to select the patient who might benefit from ECMO. I will not go in detail about in these guidelines. We'll discuss that maybe a little bit later. These are the guidelines from Australia and New Zealand. The guidelines were published a few weeks before the H1N1 pandemic. And I think it's one of the initiative which fostered the good results the Australian got during the pandemic. We also wrote guidelines just before the H1N1 pandemic. It's just the same. The management of the VV circuit in the ICU. The first question is, should we use VV or VA in patients who have refractory respiratory failure? The VV configuration is only for lung support. It has only minor cardiac effects. It will decrease RV afterload because with improved oxygenation, you will decrease the vasoconstriction of the pulmonary artery. VA, as we showed, is heart and lung support. It decreases RV preload, but it's going to increase LV afterload. So it's not good in the case of refractory respiratory failure when the heart is normally functioning. So in case of ARDS, ECMO should always be VV, just because also the Harlequin syndrome we discussed a little bit earlier. And if you go for VV, it's going to be impossible to rest the lungs, and it's very important to decrease. If you believe ECMO is going to salvage the patients, it's probably because you're going to be less aggressive with mechanical ventilation. You will decrease the pressure, decrease the tidal volumes, and it's not going to be possible if you use a VA. VA, also the problems with leg ischemia, arterial embolism, hemorrhage, which are less frequent using VV. And most studies in experienced centers use VV instead of VA in that indication. So I will skip this slide, so blood oxygenation. The setting of the circuit, so I've already shown that slide of the side of the cannulas. It's very important to use big cannulas, at least 25 French for the drainage for big patients, probably between 29 and 31. If you use 2 cannulas, probably it's better to go from to go for femoral jugular instead of jugular femoral. This was proven here by the group of Bob Bartlett. It's the setting we use now in La Pitié, between 27 and 30 French drainage cannula here with the tip of the cannula in the right atrium, and the return cannula, a short one, between 19 and 21 French from the jugular vein here. And the other setting which might be used is the Avalon. The problem with the Avalon is that more expensive, first, and second, since most of the patients we have on VV ECMO, excuse me, were retrieved from other hospitals, I think it's more easy for the mobile team to go with a setting with 2 cannulas than using the Avalon. The Avalon needs experienced doctors. It needs an experienced echocardiographer to insert the cannula, so it's a little bit more tricky. That's why we, for now, we choose to use the 2 cannula setting. More recirculation with the 2 cannulas, but still, it's working. Last important information: allow the lungs to rest. To minimize the ventilator-induced lung injury, you have to decrease plateau pressure below 25, maybe between 20 and 24. So tidal volume is going to be very low, between 1 and 3 ml per kilogram of ideal body weight. We use BiPAP ventilation in these patients now. This is data not published from the French H1N1 cohort of patients. And it's very interesting because we broke the population of patients between survivors and non-survivors. And what we've shown is that a plateau pressure under ECMO was lower for patients who survived. Most of these patients got plateau pressure below 25. And probably they got plateau pressure below 25 because the circuit was running well. For those patients who had higher plateau pressure, it's probably because doctors were forced to use higher pressure and a high volume because the ECMO system was not fully functioning, probably because the cannula were too small. Surveillance, just the same. The ECMO weaning protocol, we might discuss that later. And just a few slides. There are still skeptics for the use of VV ECMO in the context of ARDS. These are Horaf Umair from the Mayo Clinic. That's why we designed a trial which started a few months ago, which randomized patients with severe ARDS to an ECMO arm where patients got all ECMO within 2 hours following randomization, and a control group where patients are getting ECMO only if they are dying of refractory hypoxemia without ECMO, and that's it. So we have 25 minutes for discussion.
Surely somebody must have got a question.
Thank you, both of you, for covering the whole subject in an hour. I was going to ask you about the cannulation, Alain, and you partly answered it, but not quite. Most people have gone to the Avalon type cannula for the VV support, and certainly we've had good experience with it. And the advantage is, I think, the patient can be sitting out later as they're recovering, and it does seem to have a lot of advantages of being stuck, rather than being stuck in bed with the 2 cannulae. We certainly don't use echo to put it in. We use fluoroscopy and screening, we find, is the most reliable way of making sure the wires below the diaphragm and stay there. But we have started inserting it when going to pick up patients for transport in other centres. And as long as the team is used to it, it is possible. So I'm surprised, with all your vast ECMO experience, and slightly worried why you haven't embraced it. Is there something we're missing? Because I must admit, we've been converts of it. As for the rest of the people here, it's probably only been out about 2 years or so. I think they are developing a dual lumen one for the femoral vein, which will probably be even easier to put in just under blind Seldinger for transporting patients. But the triple lumen one we found has been easier to manage for the patient, especially later on when they're recovering.
Yeah, sure. I would say it's mostly at the present time for organizational issues. The mobile team uses many, it's not young doctors, it's what may be senior registrar here in the UK. So they are changing every 2 years. Clearly for the Avalon, you have to be used to the technique, experienced. Probably the learning curve is different, and you need to have at least 20 patients to be an experienced operator. And it's much simpler to use the two cannulas. It's less costly also, but it's not that big. The difference is not huge, actually. I think the Avalon cannula is the one which should be preferred in lung transplant centers. It's the cannula to be used because with the Avalon it's possible to rehabilitate the patients very early. But I agree. If we were able to use the Avalon in most patients, it would be great. The other problem with the Avalon is the size of the cannula. For big patients, you use the 31 French. 31. Yeah. So it's a very huge cannula in the neck. But anyway, it works, and it works fine. You can also use less flow with the Avalon. With these two settings, we need 5.5 liters per minute, 6.5 liters per minute in some patients to get sufficient oxygenation. Of course, because recirculation is much higher. But yeah.
I think there's a greater potential for disaster with the Avalon. It's quite a stiff cannula. If you get it wrong, particularly if you've got somebody not very experienced doing echo, you can get a looped wire and then you go all over the place with the cannula. So it is difficult to put in. I mean, I put in probably as many as anybody, but I've never ever felt comfortable putting it in. I'm always relieved when it's over. Yes. Perhaps I just say a word or two about femoral cannulation, because for those who are starting out putting in the cannulas, when you see the femoral vessels on a slide, it all looks very straightforward because you've got a nice inverted Y, and you think, well, you put the wire up there and it'll be easy. Well, what you don't see is the lateral, because the femoral vessels, they go through the inguinal ligament, and then they dive backwards into the iliacs. And there is a potential for disaster there, not so much when you place the wire as when you first place the dilators and then the cannula. And if you kink that wire at any point, you will go out the front of the vessel. And we've done that many times, I regret to say. With the older guide wires that kink more easily, it's really very easy with a stiff dilator to go out the back. So when you're putting them in, you want to make sure that there are no kinks in the wire. If you kink the wire, change it, because once that starts to happen, you can go anywhere. So if you kink the wire and you're not happy with a dilator, literally start again. And it's because conceptually you think you're going in a straight line when you're not. You're actually going in a loop round the pelvis. The other comment I'd make about the femoral artery, not so much because I've seen people make mistakes with it with ECMO, but usually with Novalung, where people are sticking these cannulas in with a wire. They forget that the crease in the groin is not the inguinal ligament, and they put them in too low. And if you put them in the superficial femoral artery, which is where they will go, with a wire-wound cannula, the femoral vessels will kink at the profunda. And once you've done that, you'll get ischemia. Mm-hmm. So the reason I'd recommend the semi-Seldinger technique, which Alain has mentioned, doing a small cut down and putting the vessels in under direct vision, is you don't do that. you put it in the common femoral, well above the profunda, and you'll have far less risk of ischemia. Whether or not you put in a reperfusion cannula will depend on the size of the vessels. If you've got something like a 21 cannula in a large femoral artery, you probably won't need to put a reperfusion thing, but at least you'll know what size vessel you've got, and more importantly, you'll know that you're in the common femoral and you're not in the junction of superficial femoral and the profunda, because if you do that, you'll get ischemia for sure.
This is very important, and we also had problems, especially when young fellows are coming and first inserting a cannula. Sometimes they are a little bit reluctant to go higher, and this is a time where we have a complication.
But these wire-wound cannulas will, particularly if the leg moves at all, they will angle the vessels and they will occlude the orifice of the superficial femoral and or the profunda.
Thanks. David Hunter Brompton. I mean, I agree with all you're saying, and the cannulation here is key. I agree with what you're saying, Richard, about the Nova lungs, and we've published about this. But if you look at the Nova lung website, they advocate putting 15 or 17 French in one push with one dilator percutaneously, which is crackers. It's much more sensible to put a couple of ports in, so you know you've got an artery on one side and a vein on the other, because it's quite easy to end up with two of one sort and then not realise until you whack something big in. So it's very sensible to use serial dilatation, and we actually open a vas cath and use the dilators from a vas cath to dilate up before we put the Nova port in. And then going back to the Avalons, we published on that as well. I agree with you entirely about the floppy wire for putting an Avalon in, punching a 31 French. I put one in somebody, I think we rang you about it actually, I put one in somebody with a nasty scoliosis last Christmas. And we always change that floppy wire for a super stiff. So we put the floppy wire in, we then pass a coronary artery catheter down, and then we exchange that for a super stiff wire. So we've got a super stiff wire that we've fluoroscoped all the way through the heart. The other thing about the Avalon, which we discovered, or I discovered last week, was that if you've got somebody on VV ECMO and you want to convert them to VA ECMO, you can't use both ports of the Avalon as drainage. The return port will not let you aspirate blood. So you end up by default then having to cut into the circuit, and you end up with VAV ECMO, which actually is not a bad idea, because you don't get the Harlequin syndrome with that. You end up with a bit of a Christmas tree return, because you've got the distal leg, proximal, and then you've got something cut into the other Avalon. But it does allow you then to wean back from VA to VV, and also to control the flow so you don't get a Harlequin syndrome. So it's quite a nice technique for that.
Yeah, the boys quite like that because it's plenty to play with.
Yeah. I don't mind it.
You work out the physiology of simultaneous VA, VV, it's quite fun. Not sure it does the patient a lot of good, but it makes everybody think.
Sophie from Glasgow. It's just a simple question. When you're doing the femoral venous with femoral, is that one in each femoral? You don't put a jugular in and a femoral?
I would say 95% of the patients now, we use the femoral jugular approach. Because when you use two cannulas in the IVC, it's you might get less flow, and it's going to be difficult to oxygenate the patient. Now it's very selected population of patients when it's impossible to access the jugular vein, that we use two cannulas in the two femoral veins. But for most patients now, it's very simple: one cannula in the femoral vein to drain, and one return cannula in the jugular veins. It's very simple. We use echo to insert the guide wire, and then in 15 minutes it's okay. The circuit is functioning.
And where do the tips of those cannulas sit?
The tip of the drainage cannula is in the right atrium, and the return cannula we use is very short, 15 centimeters. So it's basically in the jugular vein, or at the beginning of the SVC. you have to have at least 10 centimeters between the two cannulas to get less recirculation. But the recirculation occurs in all of these patients.
Sorry, can I just ask a question then? Can I ask you, when you first put somebody on ECMO for hypercarbia, how carefully and quickly do you bring down the CO2?
Yeah, it's very important, and we try to say that to the doctors and the perfusionists who go there, but I'm sure some of these patients, they go from 100 to 25 in a matter of 2 minutes. So this is not good. It's written in our protocol, but we need it's a very good issue, especially for brain problems.
I was just going to ask about the CO2 and comment as well, because I think it's very difficult. Almost as soon as you go on, the first gas you do, almost always the CO2 is corrected, never mind how much you try. So theoretically it seems to be a bad thing, but in practice it always seems to go down very quickly.
Yeah. The idea is not to go for full flow for the ventilation of the membrane. We did a little physiologic study. Oxygenation is not relying on the flow ventilating the membrane. It's with 1.52 liters, you get almost, if you have a full FiO2 100%, you get almost the full oxygenation capacity of the circuit. When you increase the flow ventilating the membrane, you're going to get rid of more CO2. So probably getting from 2 to 4 to 5, 6 in a matter of half an hour might be wise. But it's an important issue as well. Some more questions?
I just wonder if anyone's noticed when they're using the Avalon, you've got a left-sided neckline in that they have quite a raised pressure sometimes in the innominate vein. So I'm just wondering about cerebral drainage with the Avalon, and I've got some concerns that with a big cannula in the jugular, especially the Avalon going right down, that we're blocking some of the cerebral drainage. As a corollary to that, in the CO2 is, have you had any experience having NIRS on patients' forehead when you first put them on ECMO?
We've certainly not used NIRS. I mean, I've tended to put in a smaller cannula rather than a larger cannula because there is so little recirculation and you can get 4 litres flow out of a 27. The number of occasions one puts in a 31 are actually reduced.
And do you think that it's okay for the to come down on the heparin as much as is happening in Paris with the femorojugular, because you've got much higher flows, haven't you? So I wonder whether that's one of the reasons that you can chop off the heparin for so long. And I'm worried about a smaller Avalon coming down.
You've got a shorter circuit with the Avalon.
Yeah.
I mean, I worked out that the transit time for a red cell in our circuit is about 6 seconds. So they are very short circuits, and I'm trying to remember the longest we've used a circuit without heparin, but it's more than a week without the oxygenator going down or any significant clot appearing in the circuit and having to change the circuit. And really, if you keep the flow up, you can use almost only a smell of heparin and go on forever. Because even if you've not been giving heparin, there is still a small amount detectable. Because if you've been infusing heparin into the patient, it gets bound to the circuit. If you stop giving heparin, it then comes from the circuit back into the blood. So, if you do something like a TEG and you look at the 2 channels, even if they've been off heparin for 24 hours, there will still be a small amount of detectable heparin present. It's only a small amount, but it's not zero. I mean, we give 12.9 units per kilogram now. The ACT is almost a waste of time because you have to use low-reading tubes. If you use the ordinary tubes, they're normal. The nurses don't like 13, which is why it's 12.9. Not that we're being terribly scientific.
I was just going to make one more comment about the Avalon, and I agree with the question there. I must admit, we've had a few sort of cerebral bleeds that have been unexpected, and we've wondered about cerebral drainage with the Avalon. And now our protocol is we don't have any left-sided lines in when we've got necklines, when we've got an Avalon. And we're also very careful that the head is nursed in a sort of neutral position, head up, because the twist from the lines and the stiff Avalon cannula, I think, can rotate the head round to the left. And we've worried about venous drainage from the head in that situation. So we're quite careful that the head is neutral and up, and we avoid any left-sided subclavian or jugular lines when we've got an Avalon in. We've got no data on that, but it was sort of, it seemed intuitively sensible.
That's a well-known phenomenon in babies, actually.
Yeah.
Yeah. Hyperextension of the neck and cannulas in the right side.
Andy Ronald from Aberdeen. You've alluded to the TEG there. Now, are you using the TEG routinely, or are you only using it when you're having bleeding issues?
We're using it routinely, actually. It tells you a lot more than the stuff you send off to the laboratory, and you get it back in real time rather than la-la time. So we're using that, and certainly if a patient's bleeding, it really is. It's just made it so much easier.
Sorry. Do you have a protocol that you actually use based around the TEG,
No.
or just like the rest of us?
Just use the information.
Use it where it looks like.
I mean, Giles and I have had a different view about how you should manage bleeding. A protein was on that slide, and we both used to use it as an adjunct to bleeding on ECMO. I stopped using it because you could just take the heparin down. And if you stop the heparin, you get as close to normal coagulation as you can, and going to a procoagulant doesn't actually seem sensible in that respect. They're still bleeding when you've stopped heparin for more than 12 hours, then you're going to need to do something surgical. There's no way of avoiding that.
There might be also issues with the circuit, fibrinolysis induced by the circuit. If the patient has low platelet, low fibrinogen, you might need to change everything from the cannula to the circuit if the patient still needs the circuit. One last point was also very important. When you withdraw the femoral vein cannula, you have to check with echo the IVC, because I would say in 10 to 15% of the patients you might have clots in the femoral veins, and those patients might need prolonged anticoagulation following the cannula withdrawal.
What Alan mentioned there, which effectively is DIC from the circuit, not in the patient, you get the hematological appearance of DIC, but actually the clot is not intravascular, it's inside the oxygenator. We've only seen it with the Cymed, the old style oxygenator. We've not seen it with the polymethylene.
We did see that too.
You have seen it, yeah. Well, we don't use the quadrox. That may be different. But huh?
I've seen it in the pump.
Oh, yeah. But particularly in a baby, where you got an oxygenator was this big, you could defibrinate the whole patient quite easily into the oxygenator, and the oxygenator would still actually be functioning at that point, but you wouldn't revert the coagulation to normal until you change the oxygenator.